Oh, that's good. No problem. And so what we've built at eCare21 is a virtual care platform. And what does that mean? What we have is the ability to engage patients in their home or remotely, mobily, anywhere they are, and allow them to share their data within their community of care, their family members, their caregivers, as well as connect their data to a clinical documentation backend. And what that allows you to do is allow nurses and doctors and medical assistants to also be part of that circle of care. And that clinical documentation system can engage reimbursement codes or encounter codes. If it's in the US, the Centers for Medicare and Medicaid provide reimbursements. And this is allowing physicians to get reimbursed for work that they're already doing as a matter of good practice. They just don't have the technology and the workflows to be able to get the documentation they need to bill. What we provide is that easy way to document your encounters and keep track of them so that you can bill appropriately. And we will generate a clean and compliant bill with the Medicare patients. For other countries, we would look to use this virtual care platform in any way that people would want to. Say, for a personal reason, you might invite your caregivers, and for a clinical reason, you might want to engage with patients remotely. And all of the data is connected in the cloud securely and shared as the patient and the physician wish, at the level and detail that they wish. So for the most part, the patient will control access to their data from a mobile app, and the clinician will control access to the data via roles that they assign within the clinical practice. So moving on to the next slide, I will be a little bit more focused on the US problem, but this problem in healthcare applies in every country. We have a generation of people who are aging into the senior population. In the US, we say 65 and older. And currently, there are over 50 million seniors, and it's growing at a pace of about 10,000 per day. So the senior population is growing, and we need more access and capability and technology to allow us to care for that growing population, because it's outgrowing the number of people who can provide care. So we need novel and innovative ways to deliver care. In the US, Medicare has allocated about $50 billion to provide that incentive for physicians to invest in caring for those that are in the senior population. There are two programs, one for chronic care management, which requires 2 or more chronic conditions, and that reimburses at roughly on average, $45 per patient per month for 20 minutes of an encounter. And the remote patient monitoring set of codes reimburse at about $125 per patient per month for 20 minutes of assessing the patient's data at a distance. And what we've provided is the ability for you to document all of those encounters, all of those minutes, accumulate the minutes, and create a clean and compliant bill. And the billing function can also be used for any logic that you might want to encode into our system, so that if you have different CPT codes or different codes that you need to charge, they have different edits or logic, we have the ability to build that into our system to meet your needs. So more custom development is possible for you to use the platform and bill for your encounters. The other thing we do is provide a ability for you to have a caregiving application. And that allows the users of this system to invite people to care for them. And that's through a simple invite from a mobile app. Whether you're on Android or on iPhone or on a tablet or iPad mini, doesn't matter. We support those platforms, and we allow you to connect to devices, either through Bluetooth, or we now are coming out with a direct-to-cloud solution, which will completely simplify the encounter for the patient with the device, because they would simply step on the scale. There would be no need to connect via Bluetooth to the app, because the information would flow directly from the device to our secure cloud and appear in their chart for their caregivers and their physicians and carers to care for them. In the middle is an intelligent monitoring environment that is the intelligence behind the community of care that allows you to securely share the information with the parties and the stakeholders in your care. On the upper right-hand corner is a triage dashboard. This allows you to review a patient panel on the left-hand side, and in the middle, as you touch on each or click on each one of the patients, you will see the patient's data displayed in the middle, including charts and graphs to look at the trends of blood pressure, glucose, pulse ox, etc. And you also have the ability to message the patients as well as get notifications from those patients and exchange messages with them as perhaps out of bounds conditions occur. You can set blood pressure levels, weight levels, glucose levels, for instance, and as they exceed those levels, your dashboard will be receiving that alert. On the bottom right-hand corner is an example of an iPad mini use of mobile app, of our mobile app for a clinician who might be traveling remotely and need to engage with the patient remotely. They could do that via telehealth, which is available through the platform, as well as messaging, as well as calling them. So this tablet or iPhone or Android device can be used by the clinicians, by the patient, by the caregivers, all reviewing the same data about their vitals and their activity levels, their pain, their mood. Anything that you would like to record about that patient in the record can be encoded into our system and displayed in relative graphs and charts that will make sense to each of the parties that are caring for that patient. At the highest level, we're providing a population risk management platform, which allows engines for artificial intelligence to review the population and determine where the most attention is needed, where the highest risk exists, and where the highest potential to drive costs out of the system exists. And that allows us also to keep costs down. We have recently also been selected by Dell Healthcare as a virtual care platform for their enterprise customers, and that is in the process of rolling out through the Dell organization. We have been selected as one of the best caregiving apps 3 years in a row by caring.com and recently by Right at Home, one of the largest home care assistance organizations in the US. And we've also been part of various venture forums and accelerators listed down on the bottom, along with a few customer icons as samples. Our team is very strong. It includes expertise in home care, building a home care business, our CEO. Myself, I founded a security and network event management technology business, and both the CEO and myself sold those businesses, and we're now in the healthcare space focused on building better care systems for patients and for the world. Laura Schmidt is a very experienced registered nurse for over 20 years. She trains nurses nationwide in the US. Jerry Kolaski has an extreme breadth and depth in healthcare policy. He's our senior healthcare advisor and is sitting at the right hand of CMS in the US, our legislative and body, which sets the regulations for Medicare and Medicaid. He works with the Connected Health Initiative, which informs them about how systems like ours are working on the ground in reality. So the policy is being informed through our customers' use, through that channel that we provide. And Jerry is able to influence policy along with several other companies in the US that are doing the same thing. And on the right-hand side, a very strong team of advisors from senior executives at companies like Panasonic. Steve Laser from Dell Healthcare has joined our board of advisors. Michael Antonides, who is former CEO of Robert Wood Johnson, but recently joined Memodius as a VP of business. Gary Holdeby is technology executive, and Daniel Haters is from our accelerator at NextCube, and he's also a managing partner at Sway Ventures. If you look at and you focus in on the RPM program, there's a significant benefit here for simply equipping patients with devices. And the way it works in the US, and it could apply in any country, is logically you have patients who are eligible for these devices. They need it because they have comorbid conditions that require them to perhaps come in the office very often. And this can significantly reduce the number of office visits, as well as improve care and keep them out of the emergency room and the hospital. It simply is an amazing communication vehicle in the form of a mobile device. This device you can download on any smartphone. There's this app you can download on any smartphone or any tablet, and it immediately gives you the ability to invite others to care for you, as well as connect to a host of medical IoT devices. The devices we support out of the box, any device that's compatible with the Apple Health Kit or with the Google Fit software on Android. In addition, Fitbit, Withings, other big name devices, we support them as well. And we also have some specific integrations with devices that I've not mentioned, but they require some customization. It takes us roughly 2 to 3 weeks to build those integrations with new devices. But if you get a device that is compatible with the Apple Health Kit or Google Fit, most of them are, then it should plug and play. If you look at the reimbursement for RPM at $125 per patient per month, if you're dealing with a population of just maybe 1,000 patients, you're talking about millions of dollars of reimbursement that you're leaving on the table as a physician in the US. And in other countries, you will probably find a similar return on investment, where if you deploy this technology and the devices, you can increase convenience because the patient doesn't have to travel to the office, to the hospital, to the ER. They can flow their information, their vitals, up into our secure assessment environment and know that the data is safe and that their clinicians can see it as soon as you've recorded it in the system. If you don't have a device, we also have enabled our app to be able to manually record your information into the system. So if you don't have a connected device, I should have said, if you have a blood pressure meter that's not Bluetooth connected, you just take your blood pressure and enter it into our app. It immediately communicates that information up into the triage dashboard, informs the physician if anything is out of bounds, and the physician and nurses can then circle around your care and coordinate your care as a result of that and react to it. For instance, if your blood pressure was high and you are a kidney patient, your weight is increasing, they would be able to see that event and be able to perhaps recommend a change in medication or reduce or increase medication so that you will be informed about that change via the app. You will see your medication has changed. You will get a message from the physician it's changed, and then the reminders automatically will come at you at the proper times in the app. So the app gets informed by the documentation back end where the clinicians can change things, and you will be informed of those changes in your app, and all of your reminders would be re-informed and energized to trigger at the new times, letting you know that you should take your medication. Same thing with care plan tasks. If a caregiver wants to visit you, we have the ability to set up a care plan, which might require making meals, cleaning the house, taking your blood pressure and glucose on schedule. So caregivers can now provide care to you, and they can put schedules in there for things to be done. And the app for the caregiver, their app would also remind them that these things need to be done at certain times for each one of the people that they care for. And it could be a professional caregiver, or it could be just a personal or friend can set these care plan tasks up, and the app will automatically inform all parties, the patient and the caregiver, that they need to be done at certain times. When you are done with those activities, you can document them in our system, and we will keep track of the things that were done. For instance, if a blood pressure needed to be taken at a certain time, when you take your blood pressure and enter it in the system, the care plan item associated with that blood pressure would turn green. So you would not need to tap on that blood pressure icon on the screen to turn it green. We're integrated so that the devices inform the care plan as well. So there's lots of other areas I can go into in detail, but on the surface, that's the way the application works. And it's integrated. It's completely working today with customers, and we're expanding in the US and internationally through companies and partners, technology partners like Dell, for instance. In the US, there's a lot of reimbursement that's available through what is called CPT codes. And these CPT codes are encounter codes that allow the physicians to get paid for certain activities. They're increasing and have increased dramatically in 2019 and are increasing dramatically again in 2020. So what's happening is there's more encouragement and incentive for physicians to move towards preventative care. That's what this is all about, and providing more access by creating flexible access for things like telehealth, which eliminate a physician's visit because you can see the person, and with devices in the home also getting miniaturized, battery is getting better, battery life's getting better. So a lot of these new devices can now be connected to eCare21 so that in the home, you potentially will be able to take a large number of your tests while you're on a telehealth visit, for instance, so the physician or the nurse can see, or the caregiver can see what you're doing and coach you if you're not doing certain things right, and also get a sense for how you look. If you have a droopy side of the face, it might indicate a stroke is occurring. So those kinds of indicators can be viewed over a telehealth session. And if you look at a sample practice here in the US, just for 3 of the reimbursement codes, there are 12 or 13 of them, but I took 3, and the average Medicare allowable rate for a practice that has 1,000 eligible patients, and that's a middle-sized clinic in the US, more on the small side of a clinic, 6 billable physicians, you could net out, after our license fees are paid, $1.7+ million at the end of the year, because the monthly benefit to the physician for performing these functions is $158,000, and then the net for the physician is $149,000 per month. So the annual is over 1.7. And keep in mind, for chronically ill patients, once you instrument them and engage them with this kind of service, this is an extra level of service, they are very attached to it. They grow to like it. Many of the patients I've spoken to about this tell me that they don't want these devices and this connectivity to leave because it's more convenient. They connect with the nurses more often. If things get out of bounds, they feel comfortable because someone's going to call them and coach them. And the communication increase dramatically improves the care, because communication is essential. If you have that communication, you're going to be able to engage with patients more often, resolve their issues proactively, and the patient then develops a better relationship. So this is a program that is working very effectively in the US. The US is expanding it, and we expect other programs internationally to mimic this and have similar constructs where we would be able to hook into them as well. If you look at what's called a federally qualified health center, we have one in Massachusetts. The total potential reimbursement for their 2,600 patients that they've identified is roughly $3.9 million per year, using the numbers from the chart before and rolling it out to 2,600 patients. And if you look at the Medicare savings, the revenue is the reimbursement for the physician, but on the right-hand side, the Medicare savings, this is the reduction in hospitalization. Because if the patient goes in for hospitalization, there's a significant cost. And what we did was a case study at a New York City practice for a year use of the product, and they showed a 15% hospitalization reduction. And that was compared, she had a population that was over 75 on average. We compared that to an over 65 average population in the US, and we saw a 15% reduction. And that is going to be improving as she introduces remote monitoring along with chronic care management. We expect to double that reduction in hospitalization. If you look at one of the big differentiators we have, it's the community of care. This is something that many applications have tried to do, and many have fallen short because they did not have the ability to connect it to the clinical back end, which ultimately is where care is delivered at a clinical level. You have physicians, nurses, experienced practitioners who are helping to advise the patient and coach them based on their specific diagnosis on what therapies would be appropriate, whether it be exercise, nutrition, at the base level. Improving your nutrition and exercise are extremely important in care. And then it moves more towards medication management if that's needed. And then it might be something that you are more therapeutic approach for behavioral health. You might need some psychological help, and that also could be an advice from the physician or a prescription for physical therapy as well, for pains, joint replacements. You can do remote care and engage your community. And that's where the real savings are, because your community, being your friends, your family, your caregivers, are at the lowest cost. It's almost no cost for the system, for the healthcare system. But it also improves relationships between the family members, because this mobile system eCare21 has created allows everyone to share the data amongst themselves and allows the patient to invite people to care for them. And that person, if they accept it, only then can they see that patient's data. So the patient controls access to their data. And once those community members are engaged, they will now be able to provide advice. And everyone knows, they go on Google for advice. There are other databases that are reputable and curated out there that we are all becoming more educated on. So the care can be provided within the community at a lower cost and at a better level of caring, in a sense. You know best about who you're caring for if you're a friend or a family member. And in sometimes, the physician is someone that you would contact in emergencies. If you knew what to do, if you followed the general practice, ate better, slept well, and did exercise, you wouldn't have to call a physician to get advice. And people are learning how to do that. Our app encourages that information exchange and keeps the costs down and relationships up. And there is a video that you can play in this deck later on. It's available out on the internet if you search for it in YouTube. Just search for eCare21 Home Care Explainer video, and you'll find it out there. It's also on our website and on my profile on LinkedIn, as well as in Twitter. And so you can look me up, Pete Stevenson, Stevenson, and you'll find me on LinkedIn under eCare21. And if you look at the value and how this system actually progresses in value across different modes of care, from physician practices to medical groups to integrated delivery networks and accountable care organizations, you actually can see a decreasing of cost for those high-risk patients as you move from left to right. And the accountable care organizations in the US are actually moving towards capitated plans where they get a fixed amount for each patient, And then they are required to provide the breadth of care for each one of those patients. And they're personally now, as a business, are responsible for reducing costs and improving outcomes. Because if they do a good job on that capitated plan, there is a star rating improvement and a bonus that they're eligible for at the end of the cycle. So you should look at this as a way to introduce our system to physicians, but also you should look at it as a way to introduce it to your accountable care organizations, hospital systems, for instance, as well as payers who ultimately are at the most risk because they are paying for the reimbursement through insurance programs. So using this actually helps the payers reduce cost, because we'll be able to inform the payers. This is in our business plan. We'll be informing payers of where the high-risk patients exist, the cohort, and then they could provide incentives for that cohort of high-risk patients to do the right thing, take their medication on time, exercise on time. And if you follow those programs, we have a record of it, we can inform the payers along with physicians and let them know that if you wanted to, you could actually incent that cohort of good performing patients, so they will continue to do the right things by offering perhaps lower rates as an incentive for the patients to move forward in their providing better care for themselves. And likewise, for those that are not doing well, you might create incentives for them to be nudged forward in their care, to be on in that good cohort, and take advantage of perhaps lower rates for good performing patients. And there's a few quotes on the results that we've had so far. I mentioned the Best Caregiving app 3 years in a row now. A quote from Steve Laser, recognizing us as one of the first true cloud-native health applications on the market, and we're able to adapt and integrate with most existing HR platforms. We also, one of the practices using our system has been able to use this to not only generate new revenue, but she's also acknowledging that she's improved patient care. Her patients love to work with her, and she's also found it has actually reduced the number of calls coming into the practice, because the information is flowing and the patients are getting calls only when something is out of bounds. So there is a dramatic shift, because before patients were calling into our office at a much higher degree. Now they're calling in less, and the conversations are more rich and more deep about the particular patient's condition, and less about some way they felt or something they did. And that is a big improvement as well. She's been able to keep more efficient staff and focused directly on patient needs, and not be distracted by calls that might be about non-patient needs. And I also mentioned the third-party case study showing 15% reduction. That was comparing a 75 and older population with the average in New York for 65 and over. So that is also a note there. We could have generated an even higher reduction if we had an average of 65 patient population, but this particular physician is a visiting physician for patients that are over 75. So still a dramatic improvement, and it saved the system $1 million. And that is all that I have for today. If there are any questions, I'll take them right now.